Hi, welcome. My name is Susanna Weidlinger. I'm a senior physician at the Department of Gynaecological Endocrinology, Reproductive Medicine at the Inselspital, which is the University Hospital of Bern in Switzerland. In addition, I'm the president of the Swiss Society for Gynaecological Endocrinology, Contraception and Menopause. And today I want to talk to you about how to support women living with HIV during transition to menopause. Just a brief comment on the definitions. So what is menopause? The menopause is the last physiological menstruation in a woman's life. The postmenopause is the period starting 12 months after the menopause. The perimenopause is the phase of life around menopause, which starts on average at 45 years of age. And the premenopause is all the time before the menopause. So let me say a few words regarding the hormonal feedback control of the menstrual cycle. You could think of it like this. So the hypothalamus and the pituitary gland, they love somehow to bath in sex steroids. To make sure the ovaries produce estrogen, the pituitary gland releases FSH, the follicular stimulating hormone. This causes a follicle to develop in the ovary, which produces estrogen. The estrogen then is released into the bloodstream and reaches the pituitary gland and makes the hypothalamus and the pituitary gland feel well. So what happens with the oocyte count or the egg count over the course of life? We are born with around 1 million oocytes. By the time we reach puberty, this number is reduced to about 500,000. The number then remains relatively stable over the rest of our reproductive lives. However, by the age of 35, the oocytes have accumulated so much DNA damage due to cell stress, environmental toxins, etc., that DNA becomes unstable and the oocytes en masse die by apoptosis. So starting with the age of 35, the oocyte count as well as the oocyte quality decreases rapidly. You can see this here. At the time of menopause, there are no or fewer than 1,000 oocytes left in the ovaries. So with increasing age or with perimenopause, the ovary weakens. Less estrogen is produced. And the pituitary gland reacts to this with an increased release of FSH in order to stimulate the weakening ovary to produce as much estrogen as is still possible. So as you see here in premenopause, this hormonal feedback control works just perfectly. I always say it's like a Swiss watch. 1 egg is produced every month. Sometimes 2, then we have a little risk of having twins. But in summary, we are subject to minimal hormonal fluctuations. What happens in perimenopause? As you see, the whole system is completely falling apart. The ovaries are exhausted. There are times when they produce very little or no estrogen at all. Women then have hot flushes, for example. And in the next moment, due to the increased FSH tone from the pituitary gland, as I told you before, the ovaries go crazy and produce not 1 egg, as usual, as we did in premenopause, but in perimenopause, suddenly they produce 3, 4, or 5 eggs, as you see here. Estrogen levels skyrocket and are higher than ever were before menopause or in premenopause. They are extremely high. We also know that in perimenopause, there is a higher twin pregnancy rate due to that polyfollicular ovarian developments. So this is a real hormonal roller coaster. And for some women, this is nearly unbearable. It's no wonder that some women in perimenopause, they experience migraines, mastalgia, edema, and many other menopausal symptoms. And then finally comes the postmenopause. The ovary is then literally empty. There's no follicular maturation, no follicular growth anymore. And a new hormonal calm sets in at the level of an absolute estrogen deficiency. The ovary is practically dead. This situation is much more bearable for many women than this roller coaster situation in perimenopause. So perimenopause is nothing else but alternating hormonal drought and springtide, and thus so hardly bearable for some women. So how many women are symptomatic? We know that 85% of women suffer from menopausal symptoms. 1/3 are the lucky ones, they have no symptoms at all. 1/3 of women have mild to moderate symptoms, they get along quite well. And 1/3 of women have severe symptoms with a significant reduction in quality of life, and they definitely need some therapy. So my question to you is, do you feel confident in diagnosing menopause and in assessing menopausal symptoms? In 2023, one of my colleagues, Anna Hachfeld, was involved in a survey of HIV healthcare providers across the European region on this topic. And strikingly, 44% of HIV healthcare providers did not feel confident in assessing menopausal symptoms. So this is exactly the reason we are holding this webinar today. So what are the typical symptoms of menopause? Of course, hot flushes and sweating, summarized also as vasomotor symptoms, are the most important clinical parameters for diagnosing the menopausal syndrome. But there are many, many more symptoms like like heart complaints, tachycardia, palpitations, mostly reported in the evening. Sleep disorders like difficulty falling asleep, difficulty sleeping through the night, waking up much too early, not being able to fall asleep again, depressive mood, despondency, sadness, tearfulness, listlessness, mood swings. Women also report a high level of irritability, of nervousness, inner tension, massive aggressiveness, reported by their families and also by their working colleagues. Anxiety is also a menopausal symptom, inner restlessness, symptoms of panic. Then also the physical and mental exhaustion, a general reduction in performance, memory impairment, difficulty remembering or finding words, lack of concentration, forgetfulness. And then, of course, also sexual problems, changes in sexual desire, in sexual activity or sexual satisfaction. Women also complain about urinary tract problems like frequent urge to urinate or involuntary urination. What women also disturbs very much is symptoms of vulvovaginal atrophy, like dyspareunia, pain during sexual intercourse, feeling of a dry vagina, or then diffuse joint and muscle complaints. But there are much more symptoms. These are just few of many, but all of these symptoms lead to a significantly reduced quality of life. And that's why it is so important to see those women and to realize what they are going through and to induce therapy. So this is the well-known menopause rating scale, which is useful for evaluating women with menopausal symptoms, or also very useful for monitoring their response to therapy. Why is it then important for HIV specialists or infectiologists, as you are, to be confident in diagnosing menopausal symptoms? Well, it is not uncommon for patients to fear that ART therapy and not menopause is causing all the symptoms they have, and they stop taking HRT therapy. So severe menopausal symptoms can affect treatment adherence and clinical attendance. That's why I'm talking to you today. So how long does that shit last? The mean duration of vasomotor symptoms is 7.4 years, which means that every second woman suffers more than 7 years, which is pretty long. So poor overall prospects. The earlier you start suffering, for example, when the menstrual cycle is still pretty regular, the longer you will suffer. So women with a pre or early perimenopausal onset of menopausal symptoms, they will suffer 11.8 years, so even longer. And 10% of women over 70 years still have vasomotor symptoms, which is pretty tragic, I think. So at what age does menopause occur? Physiologically, menopause occurs around the age of 50 plus minus 4 years. There are even 5% of women have a late menopause. They are still menstruating when they are above 55 years of age. So early menopause is when menopause occurs between the ages of 40 and 45. Its prevalence is 10%, so pretty many women have an early menopause. Premature ovarian insufficiency, or POI, is when menopause occurs before the age of 40, and its prevalence is 1%. So 1 of 100 women has a premature ovarian insufficiency and the menopause before 40 years of age. Those two conditions are considered pathological due to the much too early loss of estrogens. In these two conditions, an HRT and hormone replacement therapy, which is an estrogen combined with the progestin, is indicated. Premature ovarian insufficiency and early menopause are not uncommon, as I just showed you, with a prevalence of 11%. So they are not uncommon conditions, but if not managed efficiently and effectively, they may have a big impact on quality of life and non-communicable diseases. POI and early menopause have significant negative effects on bone, cardiovascular, and cognitive health due to the much too early loss of the protective effect of estrogens. So we know that women with POI and early menopause, they have a higher risk for osteoporosis, for their all-over mortality is higher because their cardiovascular situation due to the early loss of the protective effects of estrogens is worse, and they also have a higher dementia risk. To sum it up, irregular periods or menopause symptoms in women below 45 years of age should be investigated promptly to facilitate timely diagnosis and therapy. In this case, hormone replacement therapy. There are different mechanisms to explain the association between earlier menopause and the increased risk of postmenopausal cardiovascular disease. We know that estrogen increases vasodilatation and inhibits the response of blood vessels to injury and to development of arteriosclerosis. The early loss of estrogen increases, for example, also the expression of inflammatory cytokines at younger ages, which might further damage the vascular function. And additionally, estrogens, we know, has a positive effect on glucose and lipid metabolism. On this slide, I want to present you a pooled analysis of individual patient data, including more than 300,000 women. And there we see that compared with women who had their menopause at a regular age of 50 to 51 years, the risk of cardiovascular disease was 50% higher in women with premature menopause, so with POI, and 30% higher in women with early menopause between 40 and 44 years of age. Each year of decrease in age at menopause was associated with a 3% increased risk of cardiovascular disease. So HRT, to sum it up, is strongly recommended at least until the average age of physiological menopause in women with POI and early menopause. And in some cases, it's recommended to not even stop HRT until the end of life to reduce the cardiovascular morbidity and mortality. So which are therapies for menopausal symptoms? We know that the classic hormone replacement therapy, which is an estrogen plus minus progestin, is the most effective therapy and superior to all other therapies. Today we'll mostly talk about the classic HRT. Of course, there are other non-hormonal treatments like different phytotherapeutics, psychotropic drugs, or completely new on the market, the neurocognitive 3 receptor antagonists, fezolinetant, and soonly coming elinzanetant. Of course, there are also non-pharmacological interventions like the cognitive behavioral therapy or yoga. So now I have told you so many good things about estrogens and HRT in general, but now why are so many women reluctant to take it? Why are so many doctors too afraid to prescribe it? This is all a relic of the WHI study from 2002, the Women's Health Initiative study. In the Women's Health Initiative study, only oral estrogens were used. So in this case, the conjugine equine estrogens. And in the second study arm, in combination with medroxyprogesterone acetate. So, and as it is usual with oral administration of estrogens, these are broken down or metabolized in the first pass mechanism in the liver. And prothrombotic proteins are formed as a byproduct. And indeed, in the WHI study, the risk of thromboembolic events was increased when taking oral estrogens. So you see there was a higher risk of deep vein thrombosis, of pulmonary embolism, and of coronary heart disease, and of stroke. We also know that from the situation with the oral contraceptive pill. It's the same in this situation. When we apply estrogens through the skin, so if we give transdermal hormone replacement therapy, then the increased risk of thromboembolism can be completely eliminated, with only a minimally increased risk of breast cancer remaining. So with the transdermal hormonal replacement therapy, we can completely eliminate those risks, and only the little higher breast cancer risk is remaining. How high is this breast cancer risk? So the basic risk of every woman to have breast cancer until she dies is 12.5%. So 1 in 8 women will get breast cancer until she dies, until the end of her life anyway. We can't do anything about that basic risk. So 1 in 8 women means from 1,000 women, 125 will anyway get breast cancer until they die. With HRT, the risk of breast cancer is increased by about 0.5 to 1 woman per year of use. So in 10 years of HRT use, the basic risk of 125 per 1,000 women will rise to 130 per 1,000 women. So this is a higher risk. I cannot deny this, but yeah, it's not devastating. I haven't even mentioned all the benefits which come along with HRT. So as you see here, HRT, women who take HRT, they have a reduced all-over mortality, death from any cause. They have 30% reduced risk for developing diabetes. They have a reduced risk for fractures and for osteoporosis, and so on and so on. So all in all, one thing is really clear: the benefit of an HRT completely outweigh the risks, and the only risk there is when you give the estrogens transdermally is a slightly higher breast cancer risk. So to sum up, the take-home message are: see your women, feel them, screen them for menopause symptoms and irregular menstruation. Use the menopause rating scale, a pretty easy to handle instrument for self-assessment or to monitor symptoms and treatment response. Offer information on menopause to your patients. Offer treatment to everybody with menopause symptoms. Women with premature ovarian insufficiency and early menopause absolutely need HRT because it can reduce the increased risk of osteoporosis, cardiovascular events, and dementia, and overall mortality that is caused by the diagnosis or the too early loss of estrogens. Transdermal estrogen, and not the oral, a way of application in combination with the progestin, if the uterus is present, is the gold standard therapy for menopausal symptoms. I thank you very much.